My name is Andrea Jackson, and I am an assistant professor in the Department of Obstetrics and Gynecology at UCSF.
Hello, my name is Alejandra Rincon, and I serve as Assistant Vice Chancellor and Chief of Staff for the Office of Diversity and Outreach.
We are the co-leaders for the Differences Matter Education Action Group, and we're going to talk to you about how we are working with the leaders in Bridges to create a program to educate our future physicians on the principles of health equity. Bridges has defined a number of core educator skills, including equity for diverse populations. This video highlights some of the work at UCSF around this issue. At the end of this presentation, you will know about UCSF's mission to diversity, specifically in the School of Medicine, the difference between health disparities and healthcare disparities, the important role of provider bias in health outcomes, our plans for incorporating the principles of health equity into the School of Medicine's curriculum, and how to find further resources to learn more about diversity and equity at UCSF and beyond. Our goal is to establish graduates from UCSF School of Medicine as leaders in the elimination of health disparities. We want to ensure that all of our graduates have the necessary skills and knowledge to give high-quality, non-biased care that promotes the well-being of all communities, but especially those that are disproportionately ill, and that is our communities of color. Despite advances in medicine, low-income and racial and ethnic minorities have worse health outcomes. For example, Blacks have higher rates of mortality from heart disease, cancer, cerebral vascular disease, and HIV than any other racial or ethnic group. American Indians disproportionately die from diabetes, liver disease, and cirrhosis. Hispanic Americans are twice as likely as non-Hispanic whites to die from diabetes. And some Asian American populations experience rates of stomach, liver, and cervical cancers that are well above national average. So where do these disparities come from? In 1999, the United States Congress commissioned the Institute of Medicine to study the issue of racial and ethnic disparities in healthcare. Their landmark study, Unequal Treatment: Confronting Racial and Ethnic Disparities in Healthcare, outlined the stark differences in outcomes based on race and ethnicity in the United States. While the etiologies for health disparities are complex, there are three major causes that most experts in this field agree upon: differences in access to health care, social determinants of health, which include the neighborhood, environmental exposures, and education. In addition, differences in the quality of health care that is provided, which is called healthcare disparities, contribute as well. Let's review what a healthcare disparity is. Healthcare disparities are defined as the occurrence of lower quality of care for disadvantaged groups that are not due to access or patient-level factors like social determinants of health. Let's review an example of the difference between a healthcare disparity and a health disparity. And let's use an example from cardiology. As we stated earlier, Blacks have higher rates of poor cardiac outcome, including coronary artery disease. This is a health disparity. However, in addition to having disproportionately higher incidence of poor outcomes, there is evidence that they do not receive standard of care with treatment, even when adjusting for socioeconomic status, comorbidities, insurance status, disease severity, and patient refusal. This is a health care disparity. So why would a physician give differential care to patients? We know that a large reason for this difference in care based on race is due to stereotyping. Stereotyping is an oversimplified idea of a person. We use it every day to organize our complex world. Unfortunately, the United States has a long history of racism that makes racial and ethnic stereotyping impossible to avoid. In medicine, we use stereotyping in the following way. We have two learning systems. The first one is slow learning. This is when information is extracted and applied rapidly and automatically and unconsciously. These are our implicit beliefs. Our second one is called fast binding. Information is extracted and applied consciously and deliberately. When there's ample time to determine the answer for a complex question, these are our explicit beliefs. When we are tired, distracted, stressed, or under time pressure, we use our automatic slow learning processes to make decisions. Again, we rely on our implicit beliefs. These conditions of being stressed and under time pressure are typical of many clinical settings. Regardless of intention or motivation, we all fall prey to using automatic cognitions or stereotypes. It is important for me to stress that our conscious beliefs are inconsistent with our unconscious behavior. Studies have shown that even when we explicitly deny bias, when our unconscious beliefs are brought to the forefront, we demonstrate this implicit bias. So the definition of implicit bias is a positive or negative mental attitude towards a person, thing, or group that a person holds at an unconscious level. While this shift from focusing on our patient's actions during a clinical encounter to our own is uncomfortable for many of us, it is the only way for us to prepare our students for delivering high-quality, equitable care to all of their patients. It is only when we confront our implicit bias and teach about all root causes of disparities that we can start to effectively eliminate these differences in health outcomes.
Our students at UCSF understood these concepts and organized in response to national coverage of the deaths of unarmed Black men by the police. On December 10, 2014, following the grand jury decisions not to indict the police officers in the cases of Michael Brown and Eric Garner, they organized a die-in to protest racism and police brutality. This event, spearheaded by UCSF students, eventually spread to over 80 U.S. medical schools. They recognized that systematic institutional racism is an important societal and medical issue and therefore started a national organization called White Coats for Black Lives. The organization has three primary goals. First, to treat racism as a public health hazard. Second, to end racial discrimination in medical care. And third, to create a physician workforce engaged with the struggle for racial justice. Their initial effort had important implications for our campus. In January 2015, the School of Medicine focused its annual retreat on diversity issues under the banner of Race Matters. This was the first time this topic had been addressed in such a direct way. In summer 2015, the Multicultural Resource Center organized a Race Matters in Healthcare exhibit, where various students and healthcare providers across campus had their pictures taken with their response to the question, "What does race equality in healthcare look like to you?" In October 2015, Chancellor Sam Hoggett announced his priority around equity and inclusion during his State of the University address. During that speech, he also recognized the students from White Coats for Black Lives for their efforts. Soon after that, the School of Medicine launched its Differences Matters initiative, which takes a comprehensive approach to diversity by developing a multi-year initiative with several groups working on issues of leadership, education, recruitment and retention, clinical trials, research, and involvement with the community. One of the groups, the Education Action Group, focuses on all matters pertaining to the curriculum. We are charged with an evaluation of the content of the curriculum, current student and faculty competencies, a review of social determinants of health, a review of systemic racism and poverty explicitly addressed in the curriculum, and the development of competencies for students and faculty, a streamlined spiral curriculum in health equity, and a certificate of excellence in core diversity and healthcare areas. Diversity efforts continued at UCSF with the February 2016 teach-in on injustice and health. Further, in May of 2016, students organized a race, police violence, and public health teach-in. This was the Chancellor's first teach-in, and it was entitled Injustice and Health. The event featured a keynote by former CNN correspondent Soledad O'Brien, and it was followed by a panel of UCSF students, residents, and faculty who explored issues around health disparities, racism, and Islamophobia. Over 1,400 people connected online, over 800 people registered to attend the event at 6 locations across our campus, and we received overwhelmingly positive feedback on the need to have more events of this nature with broader representation from other health professions.
Traditionally, the School of Medicine has not taught content on issues pertaining to ethnic and racial minorities, or if they have, it has come from a deficit perspective. Under Differences Matter, we are developing competencies for students and the faculty that trains them. We aim to address this gap in knowledge and skills by providing education and training on how to teach about racism and its impact on health access and outcomes, exploring how our individual biases affect the learning environment, including impact on issues such as grading in classroom and clinical interactions, and examining how faculty can become allies to critical issues impacting students and patients. Continuing education in medicine is not just limited to clinical issues. As a faculty educator, you have a responsibility to address your lack of knowledge around issues of racism and diversity in education as well. There are many great resources that are a good starting point, including the Association of American Medical Colleges website and their data reports on diversity. In addition, you can visit the following websites at UCSF, including the Differences Matter website, the Office for Diversity and Outreach website, and of course the White Coats for Black Lives website as well. This is an introduction to our current work in the development of a curriculum on health equity in Bridges. For more information about the Bridges curriculum, visit the Bridges website.